Remember this gem from Neuro? Alright, put down the vodka. I'm going to try to make this a little more palatable. There are many ways to understand the pharmacology, but I personally found the drugs easier to memorize than the neurotransmitters. For example, if selective serotonin reuptake inhibitors, or SSRIs, are used to treat anxiety and depression, then what do you think the patient's original serotonin was like? But since we're not yet at the pharmacology section, and since some of these drugs are legitimately hard to memorize, the next best thing is to know what the neurotransmitters do. For starters, remember from neuro that acetylcholine and dopamine have contrasting effects on movement gating at the basal ganglia. So which does which? You can think of ACH as being anti-movement and dopamine as being pro-movement. But as you may know, dopamine is also pro-psychotic, and acetylcholine is also involved in memory pathways. Dopamine, norepinephrine, serotonin, and GABA are all mood-altering neurotransmitters. Dopamine mediates the reward pathway, norepinephrine, like epinephrine, increases energy, serotonin causes happy thoughts, and GABA is the chill-out neurotransmitter. Glutamate is... alright, you got me. I don't have a really good mnemonic for this one, but it's really only relevant in one disorder. Alzheimer's disease. Now, is this a full list of what each neurotransmitter does? Definitely not. But it's certainly one way to start memorizing these bad boys. Let's start off with Alzheimer's disease. We just said that glutamate plays a role in Alzheimer's pathology, but which other neurotransmitter will most likely be affected, based on our awesome mnemonic? Hint: Alzheimer's is a disorder of memory loss. Anxiety and depression are mood disorders, so they're going to center around the mood neurotransmitters. Neither one of them is very happy. Anxious individuals are full of nervous energy and therefore suffer an inability to chillax. In contrast, depressed individuals are both sad and low energy. Finally, remember that one of the diagnostic criteria for depression is anhedonia, which means that they don't find normally pleasurable activities rewarding anymore. You can remember this with the mnemonic that depressed people have only depressed hormone levels. It's actually something you won't find in any of the other disorders. Huntington's and Parkinson's disease are movement disorders, so what do you imagine their effects are going to be on ACH and dopamine? Huntington's disease gives you all these crazy fling movements, so it's got increased dopamine and decreased ACH. Whereas Parkinson's patients move so slow, and therefore have the opposite profile. Side note, besides the movement profile found in Huntington's, another really common effect is mood disturbance, including anxiety, aggression, and other distressing symptoms. Now these folks are most certainly not chillax. And finally, possibly the highest yield of all, schizophrenia. You should know this one even without a mnemonic. What one neurotransmitter is schizophrenia known for? Hint: it's the psychotic one. Now these are just my silly ways of remembering them based on the neurotransmitters, but like I said, once you have the drugs mastered, that also becomes a really good way to remember which neurotransmitter abnormalities are present in which psych disorders. Now to briefly clue you into a couple of neuropsych definitions: orientation and amnesia. In order to be considered fully oriented, you need to know who you are, where you are, and what the approximate date or time is. Now what causes a person to be disoriented? It'd actually be almost easier to list things that can't cause a person to be disoriented. Basically, the answer is anything that can cause cerebral insult or injury. That could be a mechanical cause like trauma, or the mass effect of a tumor, a metabolic cause like hypoxia or an electrolyte abnormality, or an inflammation or infection, even if it's systemic and not localized to the CNS. Alcohol and drugs can cause delirium, and even psychiatric disorders or psych stressors, like being in an ICU, can cause delirium. When patients get disoriented, they generally lose their orientation in reverse order of difficulty. Time first, then place, and finally person. Disorientation can occur in both delirium and dementia, two similar sounding but totally different mental disorders. But hold on to that thought, because first we're going to take a quick look at amnesia. Amnesia is most often classified by the time of CNS insults into retrograde and anterograde. Now I'm sure you can figure out what they mean based on their names, right? Retrograde amnesia is memory loss for things that happened before the injury, and anterograde amnesia is the inability to form new memories after the injury. You know, like when a person has the same conversation over and over again after a brain trauma. There are many different etiologies of amnesia, Some of them are more likely to be retrograde, and others are likely to be anterograde. Korsakoff amnesia, remember that one? The one that happens in alcoholics because of a thiamine deficiency, leads to mammillary body destruction? Anyway, that one causes both anterograde and retrograde amnesia, but the anterograde is typically more severe. As you may remember from biochem, the really hilarious thing about this syndrome is that it's characterized by confabulation, which is science jargon for making stuff up. Literally, if you asked them, "What'd you do yesterday?" and they had no idea, they'd be all like, "Oh, I went to the movies with Jim Bob and we saw that new Jump Street movie I've been meaning to see." And you'd be all like, "Really? What'd you like about the new movie?" And they'd be all like, "Mostly how it was so different from the first one." And you'd be all like, "Aha, you drunk, I've got you now! It was exactly the same as the first one." And then you'd be thrown out of the hospital for aggravating the patient. Finally, dissociative amnesia is a specific kind of amnesia that happens secondary to significant emotional trauma. We're not going to talk much about this because there's a whole section on dissociative fugues and such coming up, but remember that it's a type of retrograde amnesia. Now we'll go over another important distinction in psychiatry, delirium versus dementia. They're both different flavors of what's imprecisely referred to as altered mental status. Both can cause disorientation and amnesia, but they're really enormously different entities. Delirium refers to an acute onset waxing and waning alteration of mental status, usually secondary to an acute medical process or psychological stressor. The range of etiologies for delirium is frankly enormous, but looks pretty much the same as the etiologies for disorientation. Do you remember the general categories of those etiologies? Just a refresher, delirium can be caused by mechanical etiologies like tumors or trauma, metabolic causes, inflammatory or infectious causes, intoxication or withdrawal like this gentleman here, or psychogenic causes such as acute trauma or stress. Dementia, on the other hand, is a chronic progressive decline in mental status, and unlike delirium, it's generally a disease of the elderly, and has a limited number of organic causes. By the way, what's the most common cause of dementia? The answer is Alzheimer's disease, followed by vascular or multi-infarct dementia, which is like a series of mini strokes. There's a number of others, but they go into a lot more detail for that in neuro. While there is some overlap in presentation, it's important to be able to distinguish delirium from dementia. With delirium, your consciousness and focus can lapse and you may start to hallucinate. Dementia is a lot less dramatic. Instead of popping in and out of consciousness, like I do during basic science lectures, the main deficit is memory in the early stages, followed by language. Finally, the most important distinction between the two is that delirium is a temporary symptom of an underlying condition that causes it. So to cure the delirium, you basically have to cure the condition. Until then, the quote-unquote therapy of choice is to tolerate, anticipate, and don't agitate. Not exactly the kind of therapy that wins Nobel Prizes, but it's effective nonetheless. Most forms of dementia, however, are irreversible. All the donepezil in the world isn't going to give Grandpa back his memories after the Alzheimer's strikes. But there are reversible causes of dementia, and you owe it to your patients to rule out every single one of them before you go, "Well, I guess this is your life now," and collect your big neurologist paycheck. You need to collect a TSH to make sure that the slowed mentation isn't just hypothyroidism, and a B12 study, which can also cause symptoms of dementia. Normal pressure hydrocephalus can be reversible but isn't always, but you need to shunt the excess CSF anyway to prevent progression. Finally, depression is an extremely common cause of dementia-like symptoms in the elderly. It's called pseudodementia, and you need to suspect it in any elderly patient who meets the criteria for major depressive disorder. Now, keep in mind, these are two psychiatric designations for organic disorders. They're hugely generalized, and depending on the specific etiology, there may be a huge amount of overlap. Chronic drug intoxication can lead to symptoms of dementia over time, and mechanical damage to the brain caused by a brain tumor can have an insidious onset as well. On the other side, can you think of any of the listed dementias that can have a pretty acute onset? What about Creutzfeldt-Jakob, the prion disorder? How about one that can cause hallucinations? What about Lewy body disorder? Point is, if there's a specific disorder referenced by the vignette, use your understanding of that specific disorder to answer the question. Don't just base your answers off of the delirium-dementia dichotomy. Alright folks, let's see what you remember about delirium and dementia because, you guessed it, it's flash quiz time. So, name 2 reversible causes of dementia. Go ahead and pause the video if you need some time to think. So the 3 that you're most likely going to need to know about are hypothyroidism, B12 deficiency, and depression, which is called pseudodementia if it leads to cognitive impairment. Remember, the reversible causes of dementia are super important because while most dementia is permanent and progressive, if there's any chance to diminish its effects, you need to jump right on that. Remember, you do need to know a little bit more about the etiologies of delirium and dementia than we covered, but this is the psych section. My only job is to teach you the difference between the two broad categories. Neurology should fill in a lot more about the different kinds of dementia and some of the causes of delirium. Now we're getting into the real meat and potatoes of psychiatry, the major categories of bona fide mental disorder. We'll start with a family of disorders that first started investigation into mental illness, psychosis. So psychosis at its core is an inability to experience reality normally. And the easiest way to tell if someone's psychotic if they tell you that they see stuff that isn't really there, or tell you about stuff that you know isn't true. Hallucinations and delusions are the two most instantly recognizable ways to determine if a person's psychotic or not. But it's easy to tell if someone's not entirely with it if they straight up tell you, "There's a gnome living in my ear," but what if they don't tell you? Well, one clue might be if you ask them, "What's in your ear?" and they respond with, "Ear, steer, queer, dear, fear." Disorganized speech can mean a lot of things, but for step one purposes, all you really need to know is that it's speech that doesn't make any logical or semantic sense. They may jump from topic to topic, substitute words, repeat phrases over and over, or just say things that rhyme, but it's clear from what they're saying that they're not experiencing reality like the rest of us. That might sound like a vague definition, but trust me, it'll be pretty clear from the vignettes that you read. Now, a lot of people immediately see psychotic symptoms and jump straight to schizophrenia or another one of those quote-unquote psychotic disorders. Definitely do not do that. That's going to cost you points on your test, and it's one of Step 1's favorite trap answers. Not only can psychotic symptoms be found in mood disorders, but the very definition of psychosis in the DSM-5 requires that you rule out an organic cause of those symptoms. And we're definitely going to cover in more detail some of those etiologies, but first, let's talk a little bit more about hallucinations, because these can be caused by a lot more things than just the psychotic disorders. So see that guy staring at the green figment of his imagination? Maybe some of you bohemians out there know about the green fairy, a supposedly hallucinogenic spirit called absinthe. Not, maybe you've heard of people seeing pink elephants, sort of an old-timey term for the hallucinations of alcohol withdrawal. Now, what both these visual hallucinations have in common is that they have a chemical rather than a psychological etiology. In fact, visual hallucinations generally tend to be the result of a medical condition, most famously hallucinogen intoxication or alcohol withdrawal. There's a whole bunch of other conditions that primarily cause visual hallucinations, notably narcolepsy. Narcoleptic individuals may experience hypnagogic or hypnopompic illusions. Remember which is which from the behavioral science section? Hypnagogic hallucinations occur when you go to bed, and hypnopompic illusions occur when you pop out of bed. Easy, no? So the kind of hallucinations that psychotic people get tend to be auditory hallucinations, and they usually take the form of voices. This may seem like it might just be more of an irritating distraction than anything, but you try having James Earl Jones tell you he's going to rip your bowels out of your mouth for a week straight. Then tell me how you feel. The less tested hallucinations are the olfactory and gustatory hallucinations. They're less common than either the visual or auditory hallucinations, but when they occur, they tend to occur with focal epilepsy or as a part of an epileptic aura. Olfactory hallucinations can also occur as an uncommon consequence of direct brain damage. And finally, my favorite hallucination, the tactile ones. The most likely reason you'll have to know about these is as a result of meth or cocaine abuse, or as a result of alcohol withdrawal. You get what apparently feels like bugs crawling under your skin. Ugh. So if you want to sound smart, you can use the term formication, which literally means anting. That way you can convince the twitching meth addict in the corner that you're a trustworthy young physician. Alright, after a brief diversion into hallucination land, let's talk about the prototypical psych disorder, schizophrenia. So, I told you that all of these disorders have checklists of criteria, and schizophrenia is no different. Just as a reminder, I'm going to whip through these quickly, so you're going to have to do most of the memorizing on your own. The schizophrenia criteria are like those for psychosis, with the addition of disorganized behavior, which you can think of as the action form of disorganized speech, and negative symptoms. So what constitutes a negative symptom? Well, they're distinct from the previous four positive symptoms in that they're deficits in things that people normally do. Schizophrenic patients may emote less, be less motivated, speak less, or be less expressive. Now, these symptoms are thought to be mediated by different neural pathways than the positive symptoms, because while our drugs work pretty darn well on the positive symptoms, they don't really do a whole lot for the negative ones. Furthermore, patients with predominantly negative symptoms generally have a poorer prognosis. They never become fully functional. Now, there's a bit of confusion about the natural history of schizophrenia, so while it's not super high yield, I just want to cover it to clear up the confusion. Hopefully it'll make the vignettes make a little bit more sense. So your typical vignette will start off with a 20-ish guy or a 30-ish lady out at a new job, full of potential, who after a certain point starts to get a little bit different. They may start acting strangely, missing work, maybe picking up a new religion that's actually a cult, and at a certain point, they experience a drastic decline in function that becomes a full-on psychotic break, during which their daily functioning is severely impaired. Eventually, the episode ends, but their functioning never really returns to baseline. And in fact, it keeps decreasing with each subsequent episode. So, why am I telling you this? It's not because I like the sound of my own voice, which, by the way, is as beautiful as it is captivating. One of the main things that distinguishes the psychotic disorders is the elapsed time. Schizophrenia requires that the behavior last at least 6 months. Now remember, that's 6 months from the time that the symptoms started, not 6 months since the hallucinations, delusions, etc. Remember, the first psychotic episode is usually preceded by the prodrome, during which the patient may not necessarily meet diagnostic criteria for schizophrenia. The patient will usually present to the ER around here, during which the person who brought them in will usually say, oh yeah, I guess she has been acting strange for a little less than a year. Then this last month she started peeing on the furniture and yelling something about Satan's grandson. Now, I'm not normally a stickler for specific criteria, but I am about differential diagnoses. Most of the psychotic disorders are classified by duration. A psychotic disorder lasting 6 months or longer is schizophrenia. For 1 to 6 months is schizophreniform disorder, and less than 1 month is brief psychotic disorder. And remember, the onset is counted as the onset of any symptoms, not just when the schizophrenia criteria are met. Schizoaffective disorder gets its own slide because this is one they really try to get you on with step 1. Schizoaffective disorder is basically a psychotic disorder that causes the patient to experience mood episodes. Well, what's so confusing about that? As it turns out, it's actually not uncommon for major depressive disorder or bipolar mania to cause psychosis. But not to worry, I'll make it easy on you. So, since schizoaffective disorder is primarily a psychotic disorder that causes mood episodes, the psychotic episodes define when the mood episodes occur. That is to say, the mood episodes must overlap with the psychotic episodes, but psychotic episodes can occur independently of the mood episodes. So what do you expect the overlap pattern to look like with a mood disorder with psychosis? Mood disorders only have psychosis as a part of the mood episode, generally either at the highest high or the lowest low. To further distinguish the two, schizoaffective disorder must have at least a 2-week period of psychosis during which there is no mood disorder. So why do we care? Because when it comes to treatment, schizoaffective disorder is treated as a psychotic disorder, whereas mood disorders will lose the psychotic aspect if you just treat the mood disorder. Things get a little bit more complicated when it comes to bipolar I disorder, because as you'll see, full manic patients are actually psychotic a huge portion of the time. Finally, there's one other instance of mood and psychotic symptoms I want to address, and that's bereavement. The death of a loved one is such an emotionally traumatic experience that it's not uncommon for the bereaved person to hallucinate a little bit, hear their dead relative's voice or whatnot. If it's just hallucinations and it only has to do with the relative, then it falls under the category of normal bereavement. It is normal for a person to hallucinate within 6 months of their bereavement. That means you don't treat it as either a mood disorder or a psychotic disorder. Couple last bits of trivia. Schizophrenia doesn't really show a race or gender predominance, but it does reliably start much earlier in men, and actually has a worse prognosis for them. They're associated with both genetic and environmental factors, and weirdly enough, marijuana use in teens. Nobody knows what really causes schizophrenia or the rest of the psychotic disorders, but we do know an important part of the pathophysiology of the disease. Remember the neurotransmitter? It's increased dopamine activity. For that reason, treatment of schizophrenia involves dopamine blockade with antipsychotics. And we're going to talk a lot more about the antipsychotics in the pharm section, but what you need to know now is that the first-line drugs for schizophrenia and the rest of the psychotic disorders are the atypical antipsychotics. Not because they treat negative symptoms better, that's a myth that's been busted. It's just that they have a lower incidence of significant side effects. And finally, we're going to talk about a disorder that's sort of to the sidelines of the psychotic spectrum, delusional disorder. I'll give you 3 guesses as to what it entails. Basically, the only psychotic symptom here is delusions, and it has to be present for more than a month. There usually isn't any loss of function, and the delusion has to be non-bizarre. Now, that's a highly subjective assessment, and that basically means that what the patient says could happen, but it's totally not true. Saying that Jennifer Lawrence is a secret admirer of his? Non-bizarre. Saying that the CIA is keeping tabs on him, like this strapping young man up here? Probably not bizarre, but it's kind of on the borderline. Saying that aliens removed his brain and replaced it with cottage cheese? Definitely bizarre, and that would disqualify this patient from delusional disorder. Alright everyone, that's a lot to know about the psychotic disorders, so I think we better take a time out for a flash quiz. So, a patient presents with 2 months of hallucinations and delusions following a year of anxiety and social isolation. What psychotic disorder does he or she have? Go ahead and pause the video if you need some time to think. So the point of this question is to see who was listening to me and counted the prodrome as a part of the duration of the disorder. While some of you may have jumped the gun and thought schizophreniform because of the florid psychotic symptoms, note that the prodrome of the patient acting differently has lasted for almost a year, well above the time requirements for schizophrenia.